Welcome. Continuing with its endeavor of tapping the opportunity within the adversity of the present COVID pandemic, Association of Spine Surgeons of India launches its new initiative, the Video Journal Club. In this, you will listen to key opinion leaders deliberating upon hallmark articles which have had a major impact on our clinical decision making. The stalwarts will review these articles threadbare and will highlight how it has had a major impact on our practice. And to launch this endeavor, there can't be anyone better than the great and dynamic global stalwart in publications, Dr. S. Rajasekaran. So friends, be on the lookout for the Video Journal Club of Association of Spine Surgeons of India and do share your feedback with us. This endeavor will be coordinated by Dr. Gautam Zaveri. Thank you.
So good evening, everybody. It's my privilege and pleasure to be connected to you in this new endeavor of Association of Spine Surgeons of India. So although we have been locked down by the virus, but I don't think it should be a lockdown in any one of our professional endeavors or the academic endeavors. And I should congratulate the Association of Spine Surgeons of India for this new endeavor where they are talking about research. Now, research is very important because although it's good to propagate knowledge, but if you want a leadership, if you want a legacy, then it is knowledge creation that will give that leadership. And nothing like original research which will give you this legacy. So I would like to congratulate again the association, and I would now go on to my talk for today on what is the research that influenced me most and also changed my practice. So if you see here, the topic today is that research that influenced me and changed my practice. So when you talk of this, we are talking of an original research. And I think this is something different from a regular journal club. We are not choosing an article and we are not discussing an article, but we are actually talking about a new concept. A concept that could be entirely new, or it adds a new angle to your regular practice. And ultimately, this concept has led to a change in your practice that leads a lot of benefit to the patient. So the research concept that I'm going to share with you now, and that has helped and been close to my heart for the last 2 decades, is the functional insufficiency of the posterior column and its effects on spinal instability and deformity. So what do you mean when you say functional insufficiency? Now, when we look at a radiograph like this, a pathology like what is shown here, all of us will look at the anterior column and we would say that there is a congenital fusion here. But very few of us will look at the posterior column and say that there are 2 facets which are dislocated here, which actually means that there is no destruction of the posterior column, but the posterior column has become defunct. It has become insufficient because of the dislocation of the facets. So we always add a lot of influence to the destruction or insufficiency of the anterior column. But in our practice, many times we forget that the posterior column also can become dysfunct by a dislocation of the facet joint. And this is one of the reasons that small children like this who have a major deformity and who are completely cured of the problem can end up with a massive deformity like this. So my interest and the research started with spinal tuberculosis, but you will find as you go ahead with the presentation that it is not restricted only to spinal tuberculosis. So with each of the research that I tell you, I will go on 3 steps. What was the belief and previous practice? What was the practice, research and its outcome? And how it actually changed my practice. Now, the belief when we were residents and also even in the late 90s was that spinal tuberculosis is an anterior disease and posterior column was involved only in less than 4%. That is true. But what we believed was that the anterior column destruction actually determined the outcome. And posterior column came into picture only when it was involved by destruction. So many of these patients as shown over here, we did not realize that the posterior column was becoming insufficient because the facet was actually dislocating and we didn't actually pay a lot of attention to this fact. There was also a belief, and this is one of the very well quoted articles, that after healing, age does not influence progression of deformity. As a result, children, when they are cured of the disease, when they have been cured of spinal tuberculosis, when the active disease is over, they would be followed up for a year or 2 and then subsequently discharged from practice. But this was the reason why many of them ended with a huge deformity. The first research paper that I would talk is about the natural history of post-tubercular kyphosis in children. Now, this was a landmark paper because it showed very clearly that almost all patients who had a deformity of more than 60 or 70 degrees were as the result of childhood spinal tuberculosis. Not only that, it for the first time showed that many of the children deteriorated after cure of the disease, while many actually improved. And this is the first paper that showed that this phenomenon can take place. And 17% actually showed no change. So what did we learn from this paper? We learned that adults and childhood spinal tuberculosis are completely different. Now in the adults, once they are cured of the disease, there is no change in the progress of deformity. But in children, although they have been completely cured of the disease, all through the number of years that they are growing, there is a change in deformity, and many of these children have a massive increase in deformity. It also showed that very often the changes and progress in deformity after the cure of the disease was more severe and significant than what actually happened during the activity of the disease. And this is something that was very new at that time. For example, you can see in this patient, child was cured of tuberculosis, but a massive collapse in deformity occurs after the cure of the disease because of growth modulation. Again, in a healed spinal tuberculosis, you can see over 15 years, the deformity grows from 40 degrees to 115 degrees. Now, that was the learning, that child spinal tuberculosis is in fact 2 separate diseases. In the initial phases, acute phase, it is an infectious medical disease, which is highly curable by appropriate chemotherapy. And in healed phase, thus it acts as a spinal deformity, which is modulated by biomechanics. So out of this learning, we also learned that the actual thing that caused deformity was the clinical event of facet dislocation. And between the patients who improved and the patients who deteriorated, we found that the most significant difference was the fact that all patients who had a facet and the posterior column intact improved in deformity, whereas when it dislocated, it caused a great deterioration. And that was the reason that we proposed these 4 signs, which are very well known as spine at risk signs. And this was a new knowledge at that time. So what changed in my practice due to this research? 2 important things. One is we knew that no child with spinal tuberculosis should be discharged from care even after the cure of the disease. and this was very important. They have to be followed up till the growth period is over, because many of these children showed a sudden increase after many years after the cure of the disease. And the second thing that changed in my practice was, I always say that there is no role for prophylactic spine surgery. But this was one area where prophylactic surgery was done in children whenever there is a spine at risk site. So if you have a child like this who is completely cured, no pain, child is no neurological deficit, running and active, but if two facet joints are dislocated over here, then this child requires a posterior stabilization and fusion. Otherwise, this child will have a buckling collapse of the spine. Another case where there is a cervicothoracic junctional kyphosis, you can see that the patient is completely cured of the disease, walking and running well. But if we don't operate now, this child will come back with a massive increase in deformity and a neurological deficit. And the time to operate is now. And otherwise, you will have a big problem in your hand. So this was the initial research, which did a lot of new knowledge for us. But this does not explain why some of the children spontaneously improved. Now you can see that L2 and L3 are completely collapsed over here. But at 10 years, you can see that at the anterior margin, there is a huge accelerated growth. And at 15 years, you can actually find that the fusion mass has grown faster and much in an accelerated fashion than even the normal vertebra, so that the kyphosis is spontaneously corrected. So how could this happen? In some cases in deformity, the deformity progresses. And in some cases, it shows a spontaneous resolution and even improvement. So that was the second part of this research, where we wanted to find what actually controls spinal growth and what is the biomechanical basis of growth modulation. Now, we all know that there are many papers across the time which all have mentioned that spinal growth follows Hueter-Volkmann law. Now, that is what we thought is actually true. And we know that Hueter-Volkmann law proposed a linear negative relationship between stress and growth. Now, this is a normal load, but as the load increased, you will find that the pressure on the growth plate increases, and hence growth actually comes to a stall. So distraction improves growth and compression reduces growth. And it was always a one-way phenomenon. And this was called as the vicious cycle by Ian Stokes. And we always thought that natural growth always aggravates deformity. And this was what we thought. This is a vicious cycle. But then, how could you explain this where there is a spontaneous correction of deformity from 41 degrees to 20 degrees by a sudden increase in growth of the anterior side? Now, that was the time where our interest grew in this, what is called the chondral growth force response curve. Now, this completely differs from Hueter-Volkmann law, because it says when there is a tension, the growth increases. But as you start compressing, the growth actually accelerates quite a lot in the initial phases till it reaches a plateau over here. And then it comes down quite a lot. So we wanted to find out whether the spine actually is governed by the chondral growth response curve and not the Hueter-Volkmann law. Now we know that the chondral growth response curve actually governs the growth of limbs, because you can see that's why you get a normal bowing. There is an increase of pressure on the medial side that accelerates growth, and that gives a small valgus, and then that accelerates the growth on the lateral side, and then the patient comes back to normal. This is the principle and philosophy why there is physiological bowing and physiological valgus in children. And we wanted to find out whether this is the same that happens in children. And this is the research paper that was published in Spine, which we published in 2011. And that says lumbar vertebral growth is governed by chondral growth force response curve rather than Hueter-Volkmann law. What we did this is we did it by finite element method, which is a very good method to study. And this was done, sponsored by the ISLs, and it was done in association with the Rush University of Chicago. And they had a very good FEM model. And this is the details of the FEM model which we used. But suffice it to say here that we were able to create a lot of vertebral defects, which we actually saw in many of the spinal tuberculosis children. And then we applied normal growth forces across the spine. And we were very surprised to find that the model collapsed exactly as we found that the spine was collapsing in these children. And here we found that whenever the posterior ligaments and the posterior facet was normal, and there is a wide area of contact as over here, the mechanical stress at the end plate was only 1 to 2 MPa. And the strain of the ligaments was less than 4 MPa. And in all these patients, there was an accelerated growth. Now that means that whenever the facet is intact and there is a wide contact over here, the area of force that was coming is on this plane. Initially, very minimal stress accelerated the growth. And that actually caused a spontaneous correction of 41 degrees kyphosis to 20 degrees. And then, but if there is a facet subluxation, you can see when the facet is subluxed over here, then all the point contact happens front, and we found that then the contact stress at the vertebral end plate increased by 16 times. And this was much above what was agreeable for a normal growth. And then you found that the growth started coming down quite a lot. And when the defect was much more, and you found that the collapse was crossing 40 degrees, then the strain on the posterior capsule of the facets was seen to increase beyond the acceptable level, and the facets actually dislocated. And when they dislocated, the pressure anteriorly was up to 30 MPa. And here you found that not only there were changes of the involved vertebra, but vertebra which were not involved by the disease were also undergoing a lot of changes, and multiple secondary changes and attrition of these vertebra took place, and that caused an increase of 42 degrees to 71 degrees. You can see that a normal vertebra which was not involved by the disease actually undergoing an attrition. So that led us to look at another research where we looked at 61 children treated by ambulant chemotherapy over a 15-year period. And what we really found was that many of the vertebra which was not involved by the disease, but they were within the arc of kyphosis. A lot of secondary changes took place in here. And you can see here, these are all the number of vertebra which were secondarily undergoing a deformation. And that led to a lot of change. So what did we learn? We learned that secondary changes happened in normal vertebra also within the arc of kyphosis because of increased and altered biomechanics and increasing the deformity. That meant that in any child in excess of 40 degrees of kyphosis, there were multiple secondary changes in normal vertebra within the arc, and you need to correct this kyphosis very often. We also found that whenever multiple facet joints dislocated, the normal vertebra, the involved vertebra within the lesion got posteriorly subluxed, which again consolidated as an internal kyphosis. And this resulted that the anterior column was gone and the posterior column was gone because of the facet subluxation. And this is what is related to what is called as a death of a column, where we called it as an anaconda spine. Over a period of 10 years, these vertebrae completely collapsed over here. And this is what is called as the buckling collapse of the spine in childhood spinal tuberculosis. We found that buckling collapse can be very reliably predicted in all children who are below the age of 7 years if they had a thoracolumbar involvement where there was loss of more than 2 vertebral bodies and in the presence of radiographic spine at risk signs. Now, the presence of spine at risk signs actually showed that the posterior column has gone because of facet dislocation. And if these 4 clinical condition is present, you can be absolutely sure that 10 or 15 years later, these children will undergo a buckling collapse of the spine, and the time to operate is now. Now, what were the other learning points? We learned that the functional insufficiency of the posterior column is not related only to spinal tuberculosis, but also to all childhood kyphosis. So here you can find achondroplasia child, and you can see that the facets are okay, but over a period of time. These children develop junctional kyphosis over here because you can see that the facets are dislocating over here. So you can see there is a facetal dislocation at this level and a facetal dislocation at the upper level. And as a result, you will find that these vertebrae sublux anteriorly. And because of the increased pressure, there is a suppression of growth at the anterior superior part of this body. Now, initially, we were always taught that these kinds of deformed vertebral body is a part of achondroplasia. But now we know that it is not, because these vertebrae look normal in the beginning. And only when the facets start subluxing over here, and there is an anterior translation of the superior vertebra, that these changes are secondary, and they are all the morphological growth modulation changes over here. Now, whether it is achondroplasia or a congenital kyphosis like this, whenever there is a facet dislocation seen over here like this, it is very important that we need to actually stabilize the spine quickly. Otherwise, you can see in this patient went on to more than 100 degrees of kyphosis within a very short period of time. And what is very important, you can see initially there was only one facet dislocated. But as the kyphosis increase, subsequently the adjacent facets also start dislocating, and the vertebral body in the front also undergoes a lot of changes and collapse. And the time to operate is much earlier. So with this knowledge, we went on to the last part of our research, which it gave us the knowledge to bring out a classification for kyphosis. And this was a classification which is based on column deficiency, curve magnitude, and osteotomy requirement. And this was published 2 years before in the American Journal of Bone and Joint Research. Now, for want of time, I would just say that we divided the kyphosis depending upon the present structural integrity of the column. Type 1 was where there was no deficiency of either the anterior or the posterior column. Now, if the segments were flexible, like in Scheuermann's disease, it was 1A. But if it was ankylosed, it was 1B. Type 2 kyphosis was whether there is a deficiency of either one of the column. Now, in many of the cases like spinal tuberculosis or tumoral destruction or congenital kyphosis, where the anterior column was involved, it is 2A. And if the anterior column is intact and the posterior column is gone, it is type 2B. Now, both these are very susceptible for increase in deformity. And type 3 is where both the anterior and the posterior column are gone. Now, the most important thing that this classification implies is that while in 2, it may be a slow progress. The minute it gets converted to type 3, the progress is very fast and it can proceed on to a buckling collapse. But most of the surgeons do not understand in type 2A that as the anterior column defect increases and the collapse increases, it jumps from 2A to 3 because the facets are dislocating over here. So what is very important is that we need to know that whenever there is a deformity crossing 40 degrees, we need to look at very critically the facet joints, because when the facet joint subluxes, automatically it jumps from type 2 to type 3. And after that, it's a very steady increase in deformity, and it can even go up to buckling collapse. So with this knowledge, what changed in my practice? It is the principle that a stitch in time saves 9. So when you identify this, for example, I will just illustrate this and end my talk with this child. You can see this is a very small infant. There is a congenital block vertebra over here. But more important than any of these is the fact that not only there is a problem in the anterior column, but there is a functional deficiency of the posterior column because the two facets are completely dislocated. Now, if you do not treat it now, this child will end up with a buckling collapse. And all that it required was to do, you can see that it's a very small kyphosis over here. All that it required at that time was to do a very small surgery. Nothing to be done in the front. You just do a posterior fusion and then a posterior stabilization. This was done in the year 2004 with the child almost 2 years. And you can see over the period of years, the spine is growing and also spontaneously correcting. Now, this is the child as the child is growing. And you can see when the child is 8 years old and at 16 years follow-up, you can see that the screws are still holding very well and the child has not progressed in deformity at all. And this is the patient when she is 16 years old. So a stitch in time saves 9. A very small surgery done when the child was at 2 years when the facets were dislocating. A surgery to do a posterior stabilization and fusion has completely obviated the disastrous collapse that would have ended up in a buckling collapse of this. Another child, you can see 6 years before as an infant, you can see that there is a massive loss of the anterior column. And what is more important is that you should see on the posterior column, the facets are dislocating. If we don't deal with it at this present time, thinking that the kyphosis is very small, then we will end up in a big problem. So although it's very difficult to operate in small children with the help of navigation or even otherwise with the help of fluoroscopy, you can always put in small screws and then we fused it at that stage. And you can see it has held up very well. There is a spontaneous correction and this is the boy after 6 years. So a very small surgery intervened just by posterior approach. And whenever you found that the facet was dislocating, you can see that these children correct spontaneously quite a lot and there is a restitution of growth on the anterior side. So that has helped us to come up to the principle a stitch in time saves 9. So this is the concept, that a research concept where we had gone on to look at it, document its effect on the progress of deformity. It started with spinal tuberculosis, but as I had shown you in some of the case examples, the same principle holds very well in achondroplasia. It holds very well in neurofibromatosis of children. It holds very well in congenital kyphosis. Wherever there is a deficiency of the anterior column, the minute that there is a posterior subluxation, then it relates to biomechanically the concept of death of a column. And then there is a precipitous collapse of the spine with a massive increase in deformity. We need to understand this so that we don't need to do massive surgeries later. In the Hunterian lecture in 1959, actually, Sir Reginald Watson Jones chose a topic, surgery is destined to the practice of medicine, by which he meant that all the research that you do and the progress of surgery is to identify clinical situations and to do minimal interventions so that major surgeries will not be required. And I think that this concept of identifying a posterior insufficiency by facet dislocation and a timely small surgery by a stitch in time, what you can call, will actually prevent massive surgeries which are required later. So I would like to thank the Association of Spine Surgeons of India, President Dr. Chabra for his innovative ideas, Gautam Zaveri and Kishit for arranging this. They have been doing a tremendous job during this COVID time in continuing the education in spine surgery. And thank you very much for this opportunity. It was a privilege for me to talk about this. Thank you.